Urbanization is a defining trend of the 21st century. Today, globally, over 55% of people live in urban areas. By 2050, that number is expected to rise to 68%. This rapid urbanization has a major impact on health and health systems worldwide. Rapid urbanization means strain on the public health system with challenges for urban primary health care. Lack of skilled health workers, limited available facilities and resources, insufficient medicines and supplies, high out-of-pocket expenses, and long working hours of urban residents create difficulties in accessing health care. While the diverse range of healthcare providers in cities presents opportunities for improved healthcare delivery, fostering synergy and coordination among them remains a challenge. Addressing these gaps is vital for better health and reduced inequalities in urban areas. The community-led responsive and effective urban health system Chorus Research Consortium works with urban poor communities, a range of healthcare providers in urban settings, and the policymakers to co-design solutions for different contexts. Chorus has 4 key thematic domains.
Chorus has got 4 key thematic areas, and the first of these is called the plurality of providers. The second one is around looking at the wider determinants of health, and particularly how different sectors need to come together to respond to that. The third one is about this link between communicable diseases and non-communicable diseases, and how we currently just need to respond to both of those within our health systems, particularly in urban areas. And the fourth pillar is about community engagement within city context, which is something that's really challenging to do.
Due to the inadequate service coverage of public health system, there is presence of a whole range of public, private, NGO and informal health service providers providing the first point of access for diagnosis and treatment, which is called the plurality of providers.
So plurality of providers refers to the huge range of different types of organisations and individuals who are providing healthcare. So this is a big issue in all urban areas and cities, particularly in South Asia and in sub-Saharan Africa, because within cities the public health system, particularly around primary care, is very, very minimal. There are very few public health facilities. So lots of different providers have emerged to fill the gap. So we have private pharmacies, we have private clinics, we have NGO clinics, and then we have a full range of informal providers.
Often, private sector providers such as clinics and pharmacies are the first point of contact for care. These providers adapt to the changing needs of the city life, including the conditions they treat and the hours they're open. However, this plurality can create challenges for urban health systems. Coordination and regulation across this diversity of providers is particularly challenging. Many providers are untrained or underqualified, and this is coupled with inadequate regular training and supervision from authorities. Health data is poor and rarely shared among providers and with city or health authorities to monitor and plan for better health. Chorus works with this range of healthcare providers in urban settings and the policymakers to co-design solutions for different contexts in Ghana, Nigeria, Bangladesh and Nepal to address pressing urban health issues. The Chorus partners are investigating the challenges and co-designing contextually tailored solutions to create linkages across the plurality of providers. For example, in Nepal, Chorus has established a public-private partnership model linking a primary hospital and private pharmacies to improve non-communicable disease management.
Particularly with the private pharmacies, we created the linkages between the government services, municipal health services, as well as the private pharmacies, with an interest to create a service linkage program. Service linkage basically aims to engage private pharmacy and the providers to deliver the essential care packages, which is co-designed along with the pharmacy professionals as well as the metropolitan city healthcare professionals, which are being implemented in Pokhara metropolitan city with an aim to create a functional service linkage, particularly for the non-communicable diseases, so the people who are visiting or who are utilizing the pharmacy services are taken care of with the appropriate protocol to manage them effectively, which addresses the quality of care.
In Bangladesh, CORUS works to strengthen NCD management within the urban primary healthcare system. This includes improving the NCD information system, strengthening the workforce and enhancing NCD services at urban primary healthcare facilities. CORUS study in Bangladesh found numerous challenges in addressing primary healthcare services in the cities.
In urban areas, there are diverse population. There are floating population, there are urban slum dwellers, and of course, there are upper middle income group population who also reside in urban areas. Providing primary health care to diverse and large number of urban population is a challenge. City Corporation is responsible to provide primary health care in urban areas. City Corporation has their own network of providing urban primary health care. In addition, city corporations contract non-government organizations to provide primary health care in urban areas. ARC Foundation is carrying out the study CORUS, where we are trying to strengthen the urban primary health care system to provide non-communicable disease care to urban population.
Based on the findings, CORUS Bangladesh facilitated implementation of National Protocol for Hypertension and Diabetes at primary healthcare facilities and recoding of NCD data through an app called Simple App, feeding data to the National Information Dashboard. In addition to registered private providers, informal providers are also key stakeholders in the urban healthcare landscape. The University of Nigeria is working with health and city authorities to strengthen linkages between informal health providers such as patent medicine vendors, bone setters, traditional birth attendants, and the formal health system to improve access to quality and affordable health services in urban slums.
In the urban slums that we are working in Enugu, for instance, we're in 4 slums. In Onitsha, we are working in 4 slums. So in the slums that we're working in Enugu, each of the slums actually have a primary health center that is supposed to serve the people in the urban slums as well as people elsewhere. So each PHC has its catchment population, which invariably includes the people in the urban slums. However, these primary health centers do not appear to be making proactive and intentional efforts to reach these people in the slum areas, or to even understand the peculiarities of slum dwellers so that they can better meet their health care needs. So what we are doing in our project is to try to integrate and link these informal health providers into the formal health system by improving the quality of care that they provide. So for instance, training them, providing supportive supervision, and also having them report their health records or data from their clients, strengthening referrals from informal health providers to the primary health center.
In Ghana, despite the implementation of community-based health planning and services, our CORUS study found that people were often unaware of the services, and shortage of skilled health workers logistics was also prevalent. CORUS team and stakeholders in Ghana co-designed the intervention package for enhanced life cycle health promotion and prevention services in urban poor neighborhoods. This includes education and training materials and extension of the home visits to increase health service coverage.
So what we did was to use a participatory action research approach to bring together community members, the local governments, and then the health workers to come together to find, let's say, solutions to improve or to enhance health services to the urban poor. So some of the solutions that came up was that we need to increase awareness of chips, and we also need to improve on the skills and capacities of the health workers.
Chorus works with stakeholders to develop and co-produce, implement and evaluate a package of interventions that enables sustainable provision of life cycle health promotion and prevention programs and services at household and community level for urban poor populations. The evidence we have been generating has contributed to strengthening urban health systems and primary healthcare deliveries in respective cities. In Nepal, pharmacies' data have been linked to government health information management system, indicating possible scale-up.
We have been running partnership programs, especially focusing on the non-communicable diseases. To reduce the growing burden of non-communicable diseases, both public and private health institutions play a role. Health Division has been working to identify and diagnose non-communicable diseases in the community from 11 pharmacies through this program. Services from some institutions have been incorporated in government reporting system through capacity-enhancing activities such as training and coaching. Primarily, local government is responsible to institutionalize this process. Provincial Directorate and Health Office are ready to provide technical support to this initiative.
Similarly, training initiatives on the National Protocol on Hypertension and Diabetes have been scaled up, and the use of a simple app has facilitated decision-making through segregated NCD data in Bangladesh.
With the National Protocol, the CHOs, the Honorable CHO Sir of Dhaka North City Corporation and his team, they've actually taken the initiative of training all of the healthcare workers within Dhaka North City Corporation on the National Protocol. So which actually means that our intervention has scaled up, just not across the facilities where we've been working, but across other health facilities within Dhaka North City Corporation as well. People, especially the urban poor, are getting the same diagnostic criteria, the same services, the same counseling across all of the facilities. The healthcare providers at these urban primary facilities, their capacities are strengthened. So the NCDC, the Non-Communicable Disease Control Program under the Ministry of Health, has actually wanted to take up the simple app implementation outside Dhaka as well.
Chorus bridges the gap between knowledge and practice by focusing on sustainable solutions for urban health. Our key approaches include strengthening stakeholder capacity, providing technical support to health system actors for the effective use of research evidence, and co-creating evidence-based solutions to strengthen urban health systems.
One of the aspects we should really consider is strengthening the capacity of the stakeholders. That includes the people who are providing the services, making policy changes or policy reforms. And that is one of the important things in those capacity strengthening is how to use the evidences or what kind of informations are available and use them so that you can really improve the health system.
Yeah, well, it's important to mention that a key part of Chorus is building relationships with governments. We have employed and posted research staff helping government officials and stakeholders to analyze data that is then transmitted to government from the Chorus interventions. And through such analysis, we are providing evidence to government that is helping government to, one, understand the research evidence, and then use that research evidence to then inform critical decision making that would help to improve the health of the urban poor.
By collaborating with communities and stakeholders, we are committed to translating evidence into impactful actions for equitable and more inclusive urban health systems in low and middle income countries in South Asia and West Africa.